the slides. So once again, 114th welcome to the Thursday Musings. We'll be discussing a very important practical topic, disruptive behavior disorder in children. And we have a very erudite speaker for it. Everyone will be on the mute mode except the panelists who can unmute themselves. The meeting will be recorded and available for later viewing also. You can put your questions in the chat box. Next slide, please. I'm handing over the session to Professor Dr. Tufan Pati sir. Sir is from Cuttack. He has huge organizational skills. As we can see, we are in 114th episode. Thanks to him. Sir, over to you. I'm not reading your CV.
No, please don't read. And I will also minimize your CV because we want to give maximum time to the erudite speaker we have, Dr. Deepak Gupta. We are three, myself and the moderators, Dr. Amrit Patujoshi and Dr. Alim Siddiqui. Both are vibrant, quite famous members of Indian Psychiatric Society. Dr. Alim Siddiqui has the treasury of IPS, and Dr. Amrit Patujoshi is continuing as a EC member of IPS. Next slide, please. I have the honor to introduce my dear friend, old friend, and the veteran, Dr. P.K. Singh from Patna. He has been the professor and head of the Department of Psychiatry at Patna Medical College for more than 15 years, director of a mental hospital at Koilwar in Bihar, known as Bihar State Institute of Mental Health and Neurosciences, BEAMHANS, for more than 9 years. He is chairperson of Publication Committee and CME Committee of the IPS. He is editor of IPS textbook of undergraduate psychiatry and advancing frontiers of psychiatric therapeutics. Welcome, Dr. Singh. We will be highly benefited by your kind presence. Next, we have got other chairperson, Dr. Devadatta Mahapatra. Next slide, please. Dr. Devadatta Mahapatra is assistant professor, Department of Psychiatry, AIIMS Bhubaneswar. She has got 24 publications, various national and international PubMed Index journals, 3 chapters in books. ICMR funded research project 8, other funded projects 4, index 4.1, presentation in national conferences 32, presentation in international conferences 2, award and honors, late Professor G.C. Paral Memorial Award for Best Paper, late Professor Bimbadra Das Memorial Award, Best Poster Award in international conference organized by SCARP Chennai in 2021, travel fellowship in the area of brain stimulation at Nimans, Bangalore for 2 weeks by IPS in 2021-22. Member of Life Fellow of Indian Psychiatric Society, Life Fellow of Indian Association of Child and Adolescent Mental Health, Executive Member of Indian Psychiatric Society, Odisha State Branch, Convener of Child Psychiatric Specialty Section, areas of interest, psychopharmacology, child and adolescent psychiatry, consultation liaison psychiatry, and rehabilitation psychiatry. Welcome, Devadatta. With this, I hand over the proceedings of the meeting to Dr. P.K. Singh and Dr. Devadatta Mahapatra. Your stage henceforth. Please take over. I have got a net problem over here. I am far off in Trivandrum, so I am switching off my video.
Yeah, good evening, everybody. And I thank Dr. Tufan Patti, Dr. Alim, and Dr. Patajoshi for having invited me to be associated with this session as a chairperson. It is a great occasion for me. And I also welcome all the participants who have connected themselves online from the various corners of the country. And before I proceed further and say a few words, I would like to compliment the team of the Thursday Musics for having reached this great milestone of 114th episode. And every time they have been discussing a very pertinent and seminal topic. Now, today's topic also is very, very important, as has already been announced, disruptive behavior disorders. Children, of course, are very precious. They're precious for the family, they're precious for the society, they're precious for the whole mankind, because the quality of the individual that they will grow up into will determine the quality of life in the world. And they are also important because of the size of their population. Everywhere in our own country, it is about 40% or more. Other than the children as a group, the childhood as a period of life is also very, very important. Childhood is the formative period of every individual person. And the memories of the childhood, as all of us know, they're most enduring and they last lifelong, most of it. And they have great influence on the mental health of the individual throughout life. It affects them at the conscious level. It affects also at the subconscious level. So therefore, both children as a group and childhood as a period of life, it is very, very important. And that makes child psychiatry a very important discipline of or subspecialty of psychiatry. Child psychiatry is important for the various reasons I have said and many other. Also because the diagnosis of illnesses or diagnosis of disorders of this period and their management is extremely difficult. It is difficult because childhood is a changing period, is a formative period, and every year the baseline of mental health or any health parameter keeps on changing. And that is different from the stable baseline of adulthood. Therefore, that makes it very, very difficult to make a diagnosis. And diagnosis is difficult also because the data available for this period are generally very inadequate. They are variable and often they are inadequate and fluid. And also the management of the conditions of this period is very difficult. And generally, most of us, we are not as much exposed to or have experience of this period. And today's topic is very important. It's not only important from theoretical point of view, it is also important from practical point of view. The disruptive behavior disorders of childhood, they create a lot of disruption in the order of the family, the school, and the society. And especially in the modern age, when the society have a tendency to undergo rapid changes in its structure, in its value system, in relationships, in the marital relationship, the gender relationship, etc., etc., etc. So the multifactoriality of this period is far greater than the multifactoriality of the other stable periods of life, that is the adulthood. I think with these few words, I would request Dr. Devadatta to kindly introduce the celebrated and erudite speaker, and I am sure all of us will greatly benefit from his presentation and will feel enriched and empowered to take care of such conditions. Dr. Devadatta.
Yes, thank you, sir. Good evening, everyone. At the outset, I would like to thank the organizers, Tufan Pati sir, Dr. Alim Siddiqui, and Dr. Amrit Bhai to give me the opportunity to be a chairperson in this topic, disruptive behavior disorder, which is going to be delivered by an excellent erudite speaker, Dr. Deepak Gupta. Sir is a founder and director of Child and Adolescent Wellbeing. He is a senior consultant at Sri Gangaram Hospital. He is a chairperson of Child and Adolescent Psychiatry Committee of Indian Association of Private Psychiatry. There are many awards in his credit, like Golden Aim Awards for Excellence in Leadership in Healthcare 2020, and then Eminent Medical Person Award by Delhi Medical Association 2011, and also he had received President Appreciation Award in 2010. He is the author of various books, chapters, international publications. He has presented papers at various state, national, and international conferences. His special areas of interest are autism spectrum disorder, or ADHD, and psychological trauma. With this introduction, I am not going to be in between the audience and sir. I welcome Dr. Deepak Gupta to deliver his talk. Thank you.
Yeah, please, Dr. Deepak Gupta, kindly take over. You're requested to take over.
Yeah. Good evening, everyone. First of all, I want to thank to Dr. Tufan Pati, Dr. Alim, and Dr. Amrit for inviting me to give a deliberation on this important topic. And thanks to IPS and IPS Odisha branch, I've been watching the various episodes of Thursday Musings, and it has been a learning experience from esteemed faculty and from some of my colleagues. And I'm sure this topic, which is very important, I will be able to contribute to the knowledge and learning of various people who are attending this today's webinar. So, disruptive behavior disorders in children, challenges and interventions. Now, I want to start with a small case vignette of an 11-year-old boy. There were no concerns before the lockdown because everybody talks about lockdown, so I thought I will start with the lockdown only. So there were no concerns before the lockdown. During lockdown, he started feeling lonely. He witnessed conflicts between the parents fighting with each other, and there was decreased interaction with parents being in an own room all day. This is something which we saw a lot happening with a lot of teenagers, that they got isolated and confined to their own room, arguing with the parents, aggressive with them, blaming them, fighting with them, destructive, throwing things at them, and not following instruction at home. After the physical school resumed in April 2022, he started attending school regularly. There was no behavioral or other complaint from the school. His neighbors and relatives describe him as a well-behaved boy. He complains, I don't have any problems. My parents don't understand me. They're busy fighting with each other. They are the ones who need help. I don't need any help. They should be taken for help. So this is one of the examples. On the other hand, we have another example of a 13-year-old young boy. He becomes upset with no little trigger. He starts screaming and abusing others, lies to get out of trouble, frames younger brother for his mistakes. He believes, keeps on blaming and keeps on involving his younger brother. He was caught stealing money twice from the home. He was caught smoking multiple times. Teacher reports him to be extremely rude, failing exams and bullying peers. His school doesn't want him to be in the class. He's violent towards animals, knack of kittens and puppies. There was past history of overactivity. And when interviewed, he told it is fun to bully other children and torturing animals. There's history of aggression and substance abuse in the father and grandfather. So you see these two examples. With this two examples, I want to welcome you to this important topic of disruptive behavior disorder. What is disruptive behavior disorder? Disruptive behavior disorder, also called as DBDs, they are a heterogeneous construct that encompasses a variety of symptoms, including tantrums, lying, cheating, non-compliance, theft, assault. The important thing is that when do they meet the criteria? They meet the criteria if the symptoms become severe, they are persistent, and they cause impairment in any domain, like personal, family, peer, academics. So one of few episodes of disruption or aggression, we don't call them DBDs. But if they're severe and persistent and causing impairment in any of the domains, then we have to think for DBDs. These disorders are postulated to result from poor emotional regulation and impulsivity. So the center core feature is the emotional dysregulation. More common in boys as compared to girls, and they're reflection of the child's developmental state or environmental stressor. What is important is that though the majority of these problems are temporary, but as many as 50% of preschool behavioral problems can become chronic and persist into adolescence and adulthood, which are in turn associated with substance misuse, family violence, and crime. There was a very, very important paper by Moffat in 1993 when he came out with a classical paper about this developmental taxonomy, how the early age onset of conduct disorder is more difficult and more persistent, unlike the adolescent onset conduct disorder, which is more because of the peer group. That's what. The Moffat, 1993. Now, what are the disorders which are including into DBDs? So these are the various disorders: oppositional defiant disorder, conduct disorder, and intermittent explosive disorder, pyromania, kleptomania. One disorder which is not included, but I've deliberately put it is because it has a very strong mood dysregulation, that is DMDD. DMDD was a new disorder which came in 2013 in DSM-5, but not included in ICD-11 2022. It is not grouped under disruptive behavior disorder in the current classification system, but as it frequently presents with disruptive behavior, so I've tried to put it here together. Now let's see the nosology. When we talk about DSM-5 APA 2013, it speaks about disruptive behavior, impulse control, and conduct disorder as a macro category in which the behavioral components of aggression and violation of norms are prevalent. And they put it 5 disorders there: ODD, conduct disorder, IED, intermittent explosive, kleptomania, and pyromania. But DMDD was put into depressive disorder, who also presents with irritability and episodes of aggression. But now when ICD-11 came in 2022, what they have done, they have put a category of impulse control disorder separately, which includes a diagnosis of IED, kleptomania, and pyromania. They've separated it. And ICN, what they have done, ODD and conduct disorder, they have put it only in disruptive behavior and dissocial disorder. So that is where the differentiation happens. So disruptive behavior and dissocial disorder includes ODD and conduct, and impulse control disorder separate category. And DMDD is not included in ICD-11, but what they have done is that with ODD, they have mentioned a specifier with chronic irritability and anger. So this is what I wanted to highlight while we are using this various classification while in a clinical practice. Now, briefly about a nutshell, that etiological and neurobiological profile, we know various perinatal and perinatal factors like exposure to toxins, poor quality of care. We know various biochemical and autonomic factors has been involved like serotonin, dopamine, noradrenaline, oxytocin, testosterone, cortisol. One thing I want to highlight is the neurocognitive deficits of executive functioning. That has been seen, there's difficulty in processing social information. They're not able to understand the right cues. And that is where the problem happens. And what has been seen in the various studies, scans and all, that they have a prefrontal cortex anomaly and they have a difficulty in empathy deficits. So when the scans were done, what they found was that the insular area, the ACC, anterior cingulate cortex, and amygdala, they found there was a functional disconnectivity in those areas. So that is what has been found out, that this is the one. So they are able to understand their own cues, but when it comes to the other cues, they're not able to process in the right way. And that is where the cognitive distortion happens. And that is they're not able to empathize. That is what. And it's also been found out they have a temperamental vulnerability like emotional regulation issues, impulsivity, and low frustration tolerance. We know these various risk factors for DBTs. Various we knows about it. We have heard about a lot of them like individual factor, like genetic factors, family history, low IQ, male gender, academic challenges. And the important point which I want to highlight is the attachment style, insecure and disorganized attachment style. So in conduct in these DBTs, one thing which is commonly emphasized and very strongly emphasized is the parent-child interaction. And that is a core area of treatment when we talk about the treatment of DBTs, that you work on the parent-child interaction, that small thing, it can make a difference. Early intervention is very, very important. You start early, you can save so much of difficulties and challenges in the adolescent and juvenile years. Now, family factors, we know that coercive, and this is a very important paper if anybody is interested about the Patterson, 1982, who talks about the coercive and too permissive or inconsistent parenting. Very beautiful article, classical article by Patterson, 1982. He talks about how the parenting thing is responsible for various behavioral issues. Why? If they are not able to set boundaries, if they're not able to have a limit setting, if they're not able to deal with the right cues, not able to regulate, not able to soothe the child, this leads to various behavioral disorders and issues. Drug and alcohol use by caregivers, abuse, neglect, parental criminality, parental psychopathology. This is another point which is very strongly. Parental psychopathology. Parents themselves having depression, conduct issues, alcohol, substance abuse, and modeling of aggression. Social factors, multiple social factors has been implicated in risk factors like poverty, chaotic neighborhood, peer problems, bullying, low socioeconomic status, exposure to media violence, and early departure from the family nest. What is prominent out of this is coming up in the last few years and the last 1 or 2 decades is the exposure to media violence. How 5-year-old, 7-year-old impacted by the media violence. And that is where the social responsibility comes up. That how 4-year-old child exposed to cartoons, aggressive cartoons, tends to become more aggressive, along with the poor parenting styles. and family history leads to various disruptive behavior disorders and with element of hyperactivity. So you see the multiple factors which is coming up. It's not single factor. So some genetic element, some social element, some psychological element. So biopsychosocial model, which is talked about in this thing. And the good news is that there are a lot of protective factors. So we can protect children to go into behavioral disorders, like what has been found individual, like something like again, IIQ, female gender, positive social orientation, parental monitoring and supervision, warm supportive relationship, good role models, academic excellence, extracurricular activities, encouragement from teachers toward the future, good peer relationship, and associating with peers who disapprove of violence. So a peer association, a good peer association, or a positive peer association who is able to regulate. We know that when we also were in the school, and it was a friend who was able to save us at the right time, helps us to prevent us going to a lot of bad behaviors. So these are the multiple factors which have been found out. Now let's go to the behavioral manifestation in a nutshell briefly, how it manifests with the developmental stage. Preschool children usually defiance, lack of school readiness, coercive interactive style like threatening, aggression towards peers, lack of problem-solving skills. And when they come to 7, 8 years, 6, 7, 8 years, truancy, peer problems, low academic achievements, high number of school discipline referrals, lying, stealing, aggression. And when they enter into adolescence and young age, what comes out? School failure, dropout. This is one of the very, very important things. School failure and dropouts, delinquency, drug, alcohol, poor job performance, violence at criminality, teen pregnancy, and higher death and injury rate. So do you see, this is the trajectory which is coming up. Now, if you see the hardcore symptoms of various disorder, I will not explain the various disorder. I will just want to highlight the important point. If you see the ODD, oppositional defiant disorder, the core feature is the defiance towards authority. Otherwise, they're okay with other people. People will say, oh, he's such a nice person. But when it comes to specific people like mother, father, or with a specific teacher, they are very highly defined. They're defined, they're oppositional. On a vis-a-vis conduct disorder, they're breaking age-appropriate norms and social rules, deliberately causing harm, premeditative, and lack of remorse. This is something which is very, very important. Lack of remorse, which is the important part in conduct disorder. That's why conduct disorder becomes more difficult to treat. Intermittent explosive disorder, sudden episodes of rage and unplanned. They are a relief after the episode. They have a guilt after the period of relief. This is the one, episodic and guilt. Kleptomania, mostly a recurrent irresistible urge to steal, relief after the episode, guilt after the period of relief. And in pyromania, it's the fire thing. DMDD, I have seen working with a lot of children with DMDD. And that's why I deliberately put into it. They have a severe recurrent temper outburst, more than 3 times a week. Usually start before the age of 10 years. And they keep on having it. And what is important is that they have a persistently irritable mood in between. This is the population which usually get diagnosed of bipolar disorder or adolescent bipolar disorder usually. So that's why DMD is a very, very important diagnosis which came up by DSM-5. That how people, children, adolescents who are getting diagnosis of bipolar, they were put into DMDD, this thing. And that they feel that this is a better diagnosis and better understanding of these children. So overall, if you see, in DMD, there's severe recurrent temper outbursts due to frustration. The grumpy child with regular tantrums. But intermittent explosive disorder, they are a behavioral outburst, impulsive. But conduct disorder, they have a repetitive and persistent pattern of violating rules, troublemakers, rule breakers, and ODD are anger and defiance towards authority, oppositional. Now, if we see your development trajectory in a nutshell, the childhood aggressive behavior is a strong predictor for serious negative health and your psychosocial outcomes like depression, conduct disorder, antisocial behavior, substance abuse, peer rejection, poor school performance, school dropout, and poor job performance. Very, very important article like Caspi et al. They have a longitudinal studies, they have done it, and they found it that how childhood aggression behavior are a serious strong predictor. That's why early intervention, working at 5-year-old, 6-year-old, 8-year-old is so important. The good news is that there's evidence that ODD, some evidence is that ODD is a developmental precursor of conduct disorder. Some evidence. But a majority of children with ODD never develop into the more severe conduct problem associated with conduct disorder. So around 67% or 2/3 do not meet the criteria for the diagnosis after 3-year follow-up. So people usually think that ODD will go into conduct disorder. No, 2/3 with simple interventions usually improve. They don't go into conduct disorder. Now, what I was talking about, the Moffitt thing, 1993, that is important. They talk about two types of conduct disorder, childhood onset and the adolescent onset. And they found that childhood onset conduct disorder is characterized by conduct problem and social skills originating in the early years, school age years, with increasingly severe behaviors developing through adolescent adulthood. A relatively small group of children, mostly boys, are at risk for accelerated and chronic conduct problems and psychopathology. But vis-a-vis the adolescent onset conduct disorder, it represents a large group of children who begins in adolescence. They consist of the less conduct problems and they're more influenced by a deviant peer group and a shorter duration. And that's what I've seen in practice over the last more than 2 decades, that adolescent onset conduct is more easy to handle. And when you work with them, they melt down so more easily. That's what is my experience if they're working with this population. So this is the trajectory, how ADHD, ODD, early onset conduct disorder, they go into substance use and antisocial personality. So we are more concerned with early onset conduct disorder. That is a more difficult group to treat with. Now coming to assessment. When we talk about assessment, as Professor Singh was also talking about, sir was saying, when we talk in child psychiatry, the most important thing which I always keep on telling to myself and to my students and everyone, a comprehensive assessment. Don't get biased with one opinion. That's important. So talk to the child, talk to the parents, caregivers, and always try to talk to the grandparents if you are able to talk to them. The grandparents are able to give a lot of information which you are not able to get from parents, especially in our system. What are the age of onset, duration of symptoms, behaviors in different settings, degree of functional impairment. Interview the child and the parents separately. That's one of the golden learning which I've learned over the years, is talk to the child separately and talk to the father and mother also separately. And if possible, talk to mother separately. So in that way, though it takes time, I understand, but then you are able to get more better and bigger picture. Obtain, as I told you, for multiple other sources. Remember one thing, you have to do a safety assessment also. Consider the culture variables prior to making a diagnosis. That if the child is from CCI childcare institutions or from some war-torn area or impoverished area, you have to be careful. One more important thing. These disruptive behavior disorders have significant comorbidity. So pay attention to comorbidity. And comprehensive family assessment, because the main treatment in disruptive behavior disorder is the family work and working with the families. What is the family coping style, their resources, their stressor, their social support, parenting style, their socioeconomic status, their family history, how they deal with things. So all these systems are very, very important to understand. Academic history, school report, and history of substance abuse and sexual history. Also important in disruptive behavior disorder is rule out organic conditions like head injury and seizure disorder. Some of the studies I've seen, and we have also seen, when you do EEG in some of these kids, you find they have EEG abnormalities. And in those cases, putting a mood stabilizer like an oxcarbazepine or a carbamazepine or sodium valproate has been found to be more helpful. So I've seen some of the children responding very well to oxcarbazepine or carbamazepine or sodium valproate, some of them. Assessment of the use capacity for attachment, trust, and empathy. Their cognitive functioning, mood, anxiety, suicidal potential, and taking a detailed developmental history, including the prenatal birth history, problem with the attachment, temperament, aggression, oppositional behavior, attention, impulse control. One thing which I want to very, very strongly get emphasis is to the attachment history. That's very, very important. And don't ignore abuse. Assessment of the physical and sexual abuse. Very, very high in this population, both as a victim and a perpetrator. If required, you can use psychological testing like CBCL and other, DBCL and CBCL, which can be used. And if wherever you are suspecting substance abuse, get a urine or blood drug screening. Sometimes it is very difficult because the adolescent is not ready for a testing, but he has built a rapport with the adolescent and then convince him for the testing if possible. A urine or blood drug screen, but sometimes these teenagers are very, very smart. They're very, very smart and they can manipulate the results a lot of times. So be careful in that. But be very, very strong suspicion of substance abuse if you feel there's sudden increase in the symptomatology or the behavior. Now, coming to comorbidity, as I mentioned, comorbidity is very, very high, like depression, anxiety, learning difficulties, SLD, ADHD, and substance abuse. So there's a very review article by Dr. Rajesh Sagar et al. From AIIMS. It's a very good article, 2019. Please, anybody who is interested, he has done a very, very good review article from an Indian context. And he has talked about that how put up various studies. So he's talked about the comorbidity that ADHD is frequently occurring with conduct disorder. And when there is association stronger in boys in relation to prognosis. So ADHD plus conduct disorder can have a poor prognosis. ODD along with ODD with comorbid association increased risk of substance abuse. Substance use, whenever it's there, it is with a poor prognosis. So you see more and more comorbidity, more and more poor prognosis. And mood disorder, it's highly prevalent in children with conduct disorder. A lot of time we feel they're aggressive. They can't have depression. They won't have depression. They won't have, but a lot of children, a lot of adults with conduct disorder, they have a poor self-esteem. They have depressive features. They have suicidal ideation. You work on them. They feel they can't share their own feelings. I remember when I was working in the juvenile setup in one of the juvenile homes, when I went for them, most of them, I didn't get a long chance to work with them, but limited exposure, most of them had depressive features. And they said, we don't know why it's happening with us. So mood disorder should be looked into it. So comorbidity, I always feel it's a rule rather than exception in disruptive behavior disorders. Now, the important part of my presentation, challenges. One of the top heading is challenges and interventions. And this is something which I've put it from my own experience of 25 years in this mental health field. The biggest challenge, I believe, is a comprehensive assessment. And when you're doing a comprehensive assessment, a lot of times you have a child or only one parent. It's difficult to get history from the school. It's difficult to get grandparents. It is difficult to get both the parents. And a lot of times what happens is that we have a reporting bias. Schools are not open to contribute, but yes. So reporting bias or different informant. So a comprehensive assessment is the biggest challenge. And in a busy practice, a lot of time we are in a hurry to make a diagnosis. So don't be in a hurry to make a diagnosis and start medication. I believe if you have a good rapport with a child and adolescent, if you build a good rapport with a child adolescent, that is one of the predictors of a good treatment outcome. And that's what I've learned. When I was at Maudsley in IUP Institute of Psychiatry, and lucky to have training with people like Professor Stephen Scott, Michael Rutter, Eric Taylor, I've learned so many things that go slow. Don't be in a hurry. Because if you're able to have a good rapport, you see the adolescent come back to you. If you're not able to build a good rapport with your adolescent, he will not come back to you. And that means you have a failure in the treatment. So that's one thing. So comprehensive assessment. Second important thing is underlying emotional concerns such as depression can go unrecognized, untreated. As I was talking about. So always look for depression. Be careful. The depression is usually unrecognized, untreated. And sometimes they're not ready to talk in front of parents. So talk to the young person alone. That's important. Third important thing is that smaller children, usually 5 and 6 year old, they have difficult to communicate what triggered their disruptive behavior. And that is the time using drawings, playing with them, using puppets with them, using stories with them as able to identify the triggers. So that is important is that. So smaller children, it's difficult they're able to express. So that's where I use drawings with them. And I'm able to identify a lot of times. So when they draw, there's a lot of aggression is there, a lot of red color, a lot of black color is there in their drawings. So you're able to, how they're unhappy. In the drawings, usually they're outside the house. Or there are a lot of, cutting is there. That is what is there. So I still remember one of the child, he drew a drawing where he had made 2 homes. And then he had made the skirting outside the home. And he was standing outside the house. And he had made all black those homes. And when I asked him, he was saying, I'm afraid to go inside the house. So those things, you are able to understand what is triggering their disruptive behaviors. Frequent presence of comorbidity. To look for comorbidities, that's important. The fifth important thing is that, in my experience, is that one of the bigger challenges neurodevelopmental disorders. When disruptive behaviors are present in the background of autism spectrum disorder, intellectual disability, it can be more difficult to manage. So I have a lot of children, a lot of adolescents who have intellectual disability, autism, and disruptive behavior. And when you work with them, it's their intellectual disability also comes in the way. Also their disruptive behaviors. So that is a very important population, this comorbidity. So in that way, so what happens is that they're not amenable for therapy a lot of times. The medications are not working adequately, and that becomes a difficult population. And small triggers trigger their behaviors. And the thing is that the parents at home a lot of times are not able to understand. They feel that he is doing deliberately. That becomes a problem. Many a times, when we talk about psychiatry, we talk about express emotions. Family members may have high express emotions, which aggravate the behavioral problems in children. They're highly critical, highly punitive. They keep on blaming. They keep on saying various comments to the child, and that again leads to aggravating the behavioral problems. Like today only I saw a child. The mother keeps on saying that you're like your dad, and that really triggers his behaviors. His mama keeps on saying that please don't become like your father. So these small things triggers the disruptive behavior in the adolescent. Another important thing is that, which comes a very big challenge in clinical practice, is the family work. Because the family says, only fix the child. I don't have any problem. We are absolutely fine. Fix the child. So working with the families, when you tell them this is very important, you need to work with the family. You need to work with the family as a unit. So families are reluctant to work. They say, no, the child will come for therapy. We will start the medication. No, we are busy. We can't come. It's very difficult. So that's another challenge in clinical practice. Another challenge which I've seen in the clinical practice is compliance with the medication. You start the medication, and then after a few weeks, they stop the medication, and the child and the family is often reluctant to start medication, even if it is clinically indicated. Because they read on the Google, they become Dr. Google, they get a lot of information from relatives and the neighbors and the chemist, and they're reluctant to start. Another challenge which comes in clinical practice is the polypharmacy. You start the medication, you think the child may be having underlying ADHD, the child does not respond. You start atypical antipsychotic, the child does not respond. You put a mood stabilizer, then the child gradually starts responding. But the child starts having some side effects. So need for polypharmacy along with monitoring of side effects is another big challenge. That is why there's a very, very good concept which is introduced by Dr. Pramala Santosh, who is at IOP now, who talks about that how to give minimal dose, the minimal adequate dose with minimal side effects. That is important. So we need to identify the right dose, which is the right for that particular child with minimal side effects. We don't have to be in a hurry. So go slow, start low, go slow. That's important. Another big challenge in clinical practice is the follow-ups and developing insights. Because the parents feel the child does not have any problem. I still remember a girl which I've been working with it. She has just went to Dubai for after schooling. She came to me in the class 11th. She was highly aggressive with both the parents, highly affluent family staying in South Delhi. And she was so angry with both the family. She used to hit her father, hit her mother. And the parents said that she is doing deliberately. The girl was having high suicidal tendencies, depressed, cutting herself. And now, with 2 years of medication therapy, she's better. And now she has gone to Dubai for higher studies in fine arts. And she's doing very well in the last 2 months since she has gone there. So follow-ups and developing insights, another big challenge. So these are the multiple challenges which you see in your clinical practice while working with this population disruptive behavior disorder. Now, coming to the interventions, the second part of my presentation, in interventions, it should be individualized treatment plans based on the specific surroundings in each case. Intervention should target the behaviors that have been evaluated as dysfunctional. Because of comorbidity and multiple dysfunctions, effective treatment is often multi-target, multimodal, and extensive. So that means it is not only medication, it is individual therapy, working with the child, family therapy, pharmacotherapy, and ecological interventions, which was, if you people who have read about the article by Hengeler, the multi-systemic therapy, MST, which is very difficult, which is little sometimes very not cost effective, expensive treatment, which he proposed in 1998, a classical article, Hengeler, on MST, multi-systemic therapy. I will talk briefly about that how putting everything into system, working with the child, working with the family, ecological interventions, all together for 4 to 6 months in a home in the home treatment, in the home setup, brings a big change in this population. Another thing which has come up in this population is parent training. Parent management training techniques are the most empirically supported program. Work with the family, work with the parents. The earlier you work with the families, the earlier you work with the parents. As I was talking about this family, so we started working with the parents. The father stopped coming for the treatment. Only mother used to come, and gradually we started working only with the mother. Father said, I've given up on this child. I can't do anything. So when we worked with the mother, and gradually we saw the relationship becoming better between the mother and the young girl. So she went to Dubai on a good note. So parent management trainings are the most empirically supported. Pharmacotherapy may be helpful as an adjunct to treatment for symptomatic treatment or to treat comorbid disorder. Depending on the severity, persistence, or unusualness of disruptive behavior, sometimes we need to hospitalize. Intensive and prolonged treatment and hospitalization may be necessary, because even after therapies, medication, the child's symptoms are unmanageable and the family systems are not improving. In those cases, we may have to hospitalize. That's what. Now, as I talked about the psychosocial interventions, what is the nutshell about the psychosocial interventions? The psychosocial intervention, they reduce the positive reinforcement of disruptive behavior. They increase the reinforcement of pro-social and compliant behavior. They apply consequences and punishment for disruptive behavior. Punishment typically taking the form of timeout, loss of tokens, and loss of privileges. Make the response of parent predictable, contingent, and immediate. Building the parent-child relationship and addressing the family conflict. In individual therapy, we work on the modeling exercises, role-playing, reinforcement program, problem-solving, anger management, social skill training. This is the one which I feel is the most effective, anger management skills and social skill training. So that's where the cognitive behavior therapy to help their children and adolescents to decrease the negativity and oppositional behavior. And most important thing is improving their social information processing skills. Some people have used the pet therapy, which is also called as assisted intervention with animals, in the psychotherapeutic and educational context to facilitate the empathetic attitude, contributing to emotional development of child, increasing awareness and self-regulation capacity. I have seen some of the children, that's why I deliberately mentioned this. Some of the kids, they are when you introduce a pet, especially the single child, they have improved. And especially, I'm not saying about any particular breed, but when you get some specific breed like Labrador, when they work with that, a docile dog, they're able to soothe down, they're able to get regulated with that thing. In some of the kids, some evidence is coming that pet therapy can help in such kids, some of them. Now, this is what I was talking about, multi-systemic therapy, MST, an intensive family community-based therapy treatment for serious juvenile offenders with possible substance abuse issues and their families. And it was postulated and very, very highlighted a classical paper by Hengeler in 1998, 2002, 2008. And the goal was to eliminate or significantly reduce the frequency and severity of problem behaviors. Learn skills how to better cope with family, peer, social, school, and neighborhood problems. And for parents, learn skills to independently address the inevitable difficulties that arise in raising the children and adolescents. Learn skills to help youth to cope with family, peer, school, and neighborhood problems. What was the beauty of this program was that it was short term, 4 to 6 months. Another beauty of this program was that it was in the home setup. But the only thing was that the expensive and the cost effectiveness of this program. So we need to have MST trained professionals and they have to be licensed by MST. And what it was found, one of the study which came 24 months follow-up by Sheffer et al., they found there was a reduced substance abuse and depression among mothers, improved parenting, and decreased behavioral problems among youth. But recently, in 2021, an article came up by Little et al., a meta-analysis of 23 studies done in USA, UK, Canada, Norway, and 2 more Scandinavian countries. Unfortunately, they could not find significance of MST over the years. They found that there was some short-term evidence was there, but on long-term, there was no clear-cut improvement in the youth symptoms, substance abuse, peer relationship, and school outcome. So that is what happens in anything which comes up about testing, that for short-term evidence comes up for 6 months, 8 months, 12 months, 24 months. On a long run, sometimes the evidence fails apart. That's where. So that's why I want to highlight about this multi-systemic therapy. So this is again a review article by Sagar et al., which talks about that start now in PMT and cognitive behavioral interventions, and they have a possible positive outcome. So one thing is very clear, that parent training program, child training program, starting early is effective and gives good results. That's very, very important. Now coming to the medication, pharmacological intervention, the last part of my slide presentation. Now medication for DBDs are mostly considered to be adjunctive to psychosocial interventions. So I want to again emphasize that don't just be in a hurry to start medication. Medication should not be the sole intervention in ODD, and it's not the first line treatment. What happens if you're only giving medication? You keep on increasing the dose and polypharmacy. But along with medication, if you're doing a family work, mark my words, the dose escalation is not required. And gradually you're able to minimize the dose also. Remember, you're starting a medication for a young child who are still, as Professor Singh was talking about, they're still in the developmental phase. Still the brain is evolving. Still the pruning is happening. So we have to make sure that we don't have to give too much medication. Minimal effective dose, that's important. Polypharmacy as least as possible. So combination is important. Medication trials are most effective after a strong treatment alliance. Avoid polypharmacy unless absolutely necessary. Remember, non-responsive to a specific compound should lead to a trial of another class of medication rather than the rapid addition. So a lot of time what happens, psychostimulant started, not responding, add clonidine, not responding, add risperidone, add sodium valproate. No, if they had not responded to one medication, delete it and then start another one. Change one drug at a time. That's what. And this is what, again, I learned from some of my teachers while I was at Maudsley, almost 2 decades back, that go slow. Change one drug at a time. Don't make a hodgepodge in your prescription of multiple drugs. Try to treat the primary underlying cause of disruptive behavior, whether it's ADHD, whether it's depression, whether it's anxiety. A lot of time I've seen that, especially with intellectual disability like Asperger's, like autism spectrum disorders, ASD, sometimes what happens is that anxiety leads to a lot of aggression. And there I've seen propranolol of 20 to 80 milligram really, really helping very well. So it's just working on the core anxiety sometimes. And remember, psychoeducation is a must. It's not one-day affair. It's a long-term affair. We know that. So educate the families, build relationship with them so that you are able to. You're able to. I still remember this mother who came just a few months back. She said to me, "Sir, you were right. I tried stopping the medication multiple times, but now I will not stop the medication because I realized when I give medication to my child, the quality of life of my child and mine is so far, far better. When I stop the medication abruptly without telling you, my quality of life becomes so compromised and there's a chaos in my family. I leave it to you. You gradually taper down the medication whenever it is required. My child is in your hand, Please take care of him. So this is very important, educating the families. So these are some of the medications. I've highlighted the 3 medications which have the maximum evidence and some of my favorite ones, but definitely medication have side effects. Clonidine, when nothing works, clonidine works. So 0.0, start with low again and gradually build up, and the maximum dose is 0.3 milligram per day. Some people also use higher dose, but usually 0.2 to 0.3 you're able to get good result. But be careful, don't stop it abruptly. Be careful of the hypotension and sedation. If you're suspecting underlying ADHD, methylphenidate, start with 5 to 10 milligram, gradually build up, maximum to 60 milligrams. Some people have even gone to 80, sometimes I have gone, but be careful of the decreased appetite and sleep disturbances. Sometimes you have to go, and a lot of times, a single dose, long acting. Now we have a long acting preparation of 18 milligram, 3654. Sometimes I've seen they're giving a better sustained delivery and better compliance. Atomoxetine, start with low 0.5 and gradually build up to 1.2. Sometimes I've seen, because a lot of referrals comes to me, sometimes we are able to stop. We don't give atomoxetine to the right dose. So try to build up gradually. But the only problem come with atomoxetine is the weight loss and appetite loss. This is a very, very important thing. But go slowly and gradually build up. Atomoxetine is a good molecule, but methylphenidate has more effect size than atomoxetine. And sometimes you have to combine atomoxetine or methylphenidate with clonidine to get a far better results. Risperidone again, but the most important thing with risperidone is the sedation and the weight gain. More than sedation, the weight gain is a big challenge. Start low again with 0.125 to 0.25 and gradually build up. Usually 1 to 2 milligram is good enough for me to get good results. Aripiprazole is my better preference over risperidone because of less weight gain and less sedation and less akathisia. But yes, and usually I start with 2 to 5 milligram and gradually build up to 10 to 20. But my maximum usually 5 to 10 milligram per day, I'm able to get very good results. Olanzapine is a very good molecule, but usually weight gain and increased appetite is something which scares me and which I've seen in a lot of youngsters, and this there, they tend to a lot of weight gain. Fluoxetine is for depression, lithium, and coming to the mood stabilizer, lithium divalproate, oxcarbazepine. Yes, in sometimes when those other molecules are not working, adding lithium, divalproate, oxcarbazepine, they can have very good results. But be careful of side effects. And if the EEG changes are there, or history of head injury is there, or history of seizure episodes in the past is there, you know these are the simple cues that these molecules can respond, that the child can respond better to these anti-epileptics or mood stabilizers, far better. So in a nutshell, by Sagar et al., risperidone was superior to placebo in reducing aggression. The Cochrane review found that risperidone reduced aggression and conduct problem in DBTs. And systemic review and meta-analysis found that psychostimulants have a moderate to large effect on symptom regulation, and atomoxetine a small effect on aggression. And clonidine had a moderate effect size on symptoms of ADHD, especially in ADHD comorbid conduct disorder. So clonidine, psychostimulants, and risperidone stands apart in various meta-analyses. Now, to just the last part of my presentation, I just want to talk about the preventive strategy. And one of my professors, Stephen Scott, I was lucky he was one of my teachers while I was at Maudsley, who used to say always, and still right now he's a professor of child mental health in Maudsley Islam. He says that DBTs, if not nipped in the bud, it impacts the child's overall mental and physical health, education attainment, occupation, social relationship, family functioning, more conflict with the legal system, and 10 times more cost of treatment. So if you're able to intervene early, 4 years, 5 years, 6 years with parenting simple programs, you're able to prevent 10 times more cost, which goes on the mental health, legal system, juvenile system, child welfare system, and the education system. And various preventive strategies are there, addressing parenting behavior, family conflict, targeting social cognitive social skill deficits, addressing learning difficulties, common adolescent problems, treating primary psychopathology. And that's why treating ADHD and depression in adolescents and children should be adequate. Raising awareness and camp services to be made affordable and accessible. So overall, in a nutshell, prevention, that means maternal health, parenting and family work, addressing learning and peer problems. We know the risk factors are low IQ, academic problems, family conflicts, peer problems, and a big list is there. How it manifests, DBTs manifest by defiance, aggression, breaking rules. In assessment, multiple sources, look for comorbidity, look for abuse, and the important thing, look for family dysfunction. Never ignore the child. The child version of the problem is very, very important. Work with the child, work by the child, work for the child. That's important. Rating scales and drug screens if indicated. And in management, in a nutshell, psychological strategies involving problem solving, anger management, family therapies, and in pharmacological, various medication, including aripiprazole, risperidone, quinine, and methylphenidate. So take home message, the last slide of my presentation. The DBTs are common in childhood as the child is developing and trying to adjust to the environment. If not appropriately addressed, they can become chronic and persist into adolescent and adulthood. It can be early presentation of developmental, learning, or mental health problems and may reflect the presence of social stressors in the environment. A comprehensive evaluation of presenting behavior, including the social and environmental settings that may be triggering such behavior in child, is important. And the last important point is that behavior interventions are the first line of management. Parent management training, family counseling, most empirically supported programs, and medication should be considered when the behavior management fails. Thank you very much. Thank you once again for giving me this opportunity to present my perspective. Thank you very much.
Thank you so much. Really nice overview. Over to chairpersons.
Well, I would like to thank Dr. Deepak Gupta for an extremely comprehensive and lucid presentation of a very complex area, which requires the involvement of multiple level workers in the society. And since we are getting short of time, I would request the moderators to kindly take up the questions and comments from the online audience.
Dr. Alim, Philip John sir has raised his hands.
Okay.
Can we?
Sure.
Sir,
Philip, sir.
Yeah, can I unmute?
Yeah,
Yes,
you
please,
have
sir.
Yes.
audible now.
I'm audible now.
Yes, sir.
I just wanted to thank Deepak for the wonderful presentation.
Thank you, sir.
I am in total agreement with this comment on the parenting part. Parenting is a huge problem that gives rise to any type of oppositional or conduct disorder in children. One of the things that I have been talking about, we have a parenting module too. We talk about avoidance of two things in parenting. One is parental undermining. The father says no and the mother makes it yes. And parental double bind. The mother says no and then she makes it yes after 15 minutes. This is one thing that makes the child manipulate behavior, and then slowly he gets outside the limits. And that's what I am coming to. As you rightly said, structured environment and limit setting, that is what will actually make this particular problem get under control and even prevent it when the children are growing up. That's one. Second part is I quite disagree with you in terms of your positioning of the medications. Because I look at ODD or any of these things after 40 years of working with this group of our children, I have a very definite idea that most of these children, they have problems other than the behavioral, which are related to their neurodevelopmental disorders, which is showed in one slide. The neurodevelopmental disorders inordinately give rise to the difficulties with respect to the frustration management. They have an intolerance of frustration. Many of them have intolerance of disapproval because of the constant disapproval that they get because of the academic difficulties at home. I mean, in school, they get to tend to be oppositional at home. There are difficulties which are related to their difficulty to tolerate criticism, which they often have to confront. And they themselves do not know why they are being criticized, because the problems lie with their difficulty with reading, written comprehension, reading comprehension and writing. And therefore, when they are unaware of this, they have to take out this frustration somewhere. And that's how it begins. And then this becomes a parent to child proposition of competing. And that gives rise to their growing disturbances in frustration and this negative behavior. The third thing, and which is the most prominent thing, is I have been talking about this since about 20 years now, that all neurodevelopmental disorders, whether they are communication disorders, language disorders, speech disorders, learning disorders, coordination disorders, even as you said, intellectual developmental disorder, all these are actually probably the same basket, because they have the same genetic underpinnings, they have the same epigenetic underpinnings, they have similar signal transduction as well as interneuronal signal transmission difficulties. So basically, when it comes to this, when you put all these underpinnings together, there is one thing that we miss, and that is the juvenile OCD or juvenile obsessive traits that we miss. Many of these children, they have a juvenile OCD traits, and now after Daniel Gelder's papers, our views are being actually agreed upon. Now, when you look at these children, and that's one of the reasons why there is a need to introduce a comprehensive evaluation where you positively include obsessive traits. And you find that many of the parents who have this difficulty with emotional expression at home, many of them are actually very strongly obsessive or compulsive with the OC traits. So it's very important that we actually get hold of this and in the management of this disorder, including medication. Now, including medication, ADHD, I think, is a common underpinning to all these neurodevelopmental disorders. So unless you control that, there's no point in just trying to get him to sit and listen to you and do behavioral management. Absolutely. So I think in all these, therefore, we have to look at the comprehensive evaluation of all these NDDs, all the neurodevelopmental disorders, including OCD, and treat them right from the beginning, along with the behavioral management and family management. And medications that I very definitely use in plenty, methylphenidate, but in much smaller doses than the West needs to use. Because if you have parental management, you will find that you will need to use only much less medication. You will need an adequate dose of, I use fluoxamine because it's the one that you can start much earlier in life. And there is definitely a need, as you said, for carbamazepine or oxcarbazepine. I use a lot of carbamazepine, but very, very carefully, because that is where the neuronal stability is achieved and the interneuronal transmission is increased because the VSSC and the ligand-gated signal transmission. Basically, I think if you put all these things together, I think the medications have a role right from the beginning, right from day one. But then we should increase it, as you said, very, very carefully after psychoeducation and consent from the parents. Thank you very much for that presentation.
Thank you. Just a brief comment on all these, or 3 points very briefly. Yes, limit setting is also required because it creates a structure for the brain. Because as the brain is very chaotic, limit setting gives you a structure to your brain and to the whole system. Correct. That's one thing. Second thing, I totally agree. But see, why important is that you have to understand that the point is that if there's a neurodevelopmental disorders, along with it, definitely you will consider the medications from starting, like if ADHD is there. But some of the times, if it's not there, what I meant was that if it's only ODD is there and no ADHD, don't think for medication. You start with parent training program. You should not jump to it. So you have to evaluate things where it is required, you start. You should not be there, just start medication from day one. That's what I meant is that, especially to the young colleagues that have a comprehensive evaluation and then see when it is required. The third thing about the spectrum thing, yes, people talk about spectrum, this thing that everything is on the spectrum now. But yes, we have to see that on which part of the spectrum. It is only pure DBTs or is DBT plus neurodevelopmental disorders, and then look for other disorders also. So my only humble request to everyone is that don't go for the only your best combinations. Do a comprehensive evaluation, involve the parents. Parent training program should be given emphasis along with medication if required, as per the child to child and case to case.
Thank you, sir. A very common question that we come across regarding medications: what are the lowest ages where we can safely prescribe, or when we can extend the age to the lowest versions?
See, as you see, Dr. Alim, the thing is that most of the guidelines says after 5 years. But you can low down to 4 years. And if at the age of 3 years, the symptoms are unmanageable, then you can even start the medication at the age of 3 years. But be very, very careful and start ultra low dose. That's important thing. But safely you can low down as per the new some of the guidelines. By 4 years you can start, but in 3 to 5 years of age, again, the first line of intervention should be behavioral intervention. Correct. And if it's that not, if that is not improving the symptoms, if you feel it is falling apart, then you add ultra low dose and gradually build up.
Sir, what would be the references for it? Because it is a very dicey proposition.
You read about the PAD study. There's a PAD study which came about. The PAD study is there. Preschooler, adolescent, preschooler with ADHD treatment study, which was done many years back. That is the that talks about how 3 to 4 year old, 3 to 5 year old can be used with medication. But again, they say the PAD study clearly says that please start the behavior intervention, and then if required, you start the medication. Also, after the PAD study, they have said that after the age of 4 years, you can evaluate for ADHD. In some of the cases,
I have a corollary.
In some of the cases, Dr. One second, Dr. Amit, in some of the cases, for 3 to 4 years old, I have started 1 or 2 drops of risperidone also. I have started 0.5 milligram aripiprazole also. Correct? I have done that, and I have seen the results also. But that is case to case. That is case to case, depending on the situation and case to case.
Sir, I would like to add, suppose somebody has come from village.
Yeah,
somebody has come from, he comes in the morning and he has been showing to a lot of people, a lot of doctors. Now you cannot have a PMT or any behavioral management. They're uneducated. It's very difficult. You know that the parents are at their age, managing such a child who is throwing stones, who is going somewhere, putting his hands hitting people. So there we are sometimes forced to add medication.
Absolutely, I have done that. That's what
and I have given medication for 2-year-old kids also, because we have found good results. Maybe yes. So I think it's dicey,
because a lot of youngsters are also attending. I don't want to encourage pharmacy, psychopharmacology for 2 to 5 year old. Let me tell you, because when you hear in any presentation, you get tempted to start. So I don't want to encourage for 2 to 5 year old medication. But yes, in exceptional cases, case to case, like as you said, the family comes to me from village, from a remote area in Haryana, and highly disruptive behavior. I know parent training program cannot be done. They're not amenable. So I end up starting them into a few drops of risperidone. And when they come for a follow-up, after 1 month, the child is better. So yes, case to case you can be done, but psychopharmacology should not be encouraged for 2 to 5 year old. That's what I want to emphasize.
Okay, sir. Sir, there is a question, very important question. What to do actually in anger management? A few tips for it. How does it go about?
Anger management of parents or child?
Of child.
So my first thing is that when I work with anger management, I always look for the anger of the parent. That's why I asked you this question. Correct? Unless I don't work on the parent, if you again, the age of the child is important. So if you're working for a 5-year-old, 6-year-old, and if parents themselves have anger issues, emotional regulation issues, unless you don't work on the parents' own emotions and anger, you will not get success. So in those cases, I involve my team, I involve my psychologists to work on the parents' own emotions and own anger. That's one thing. Now for children, there are multiple strategies are there depending on the age. For the 4-year-old, 6-year-old, 8-year-old, depending on the various strategies are there. Now, multiple strategies are there which can be done. Simple strategies are there for the anger management, from breathing techniques to counting backward, to drinking, to walking, to think about music, to jumping jack, to crossing their fingers, to pressing their feet on the floor. Those things are there. Also, one more important thing is that I always use the ABC, antecedent, behavior, and consequence. When you use such a diary, ABC, you're able to identify the triggers. When you're able to identify the triggers, especially the A, what is leading to behavior and the other things, you're able to modulate and modify those A antecedents. So in those cases, you're able to tell the child whenever such antecedents happens, what it should be your approach. And sometimes it can be a bullying. Sometimes it could be a nasty comment by a sibling. Sometimes could be like hitting by the cousin brother. It could be by sometimes watching parents fighting. So it could be various triggers, A, which are leading to disruptive behaviors. So in such cases, you're able to work on those. So ABC, simple anger strategies, and working on the parents. Those are the important things out there.
And so there are a few questions regarding comorbidities. So suppose the picture is complicated by partially addition of comorbidities. So LDs, autism spectrum, then dissociation, multiple somatic complaints, all these are being mentioned in the chat box. So as the other symptoms keep adding on, how does the management vary, or what we should look about?
See, the important thing again, in such cases, if a complex presentation comes to us, so I always believe, make things simple. So whenever you have a complex presentation, try to make it simple. And how do you make it simple? You need to identify, spend time with the child and the family. When you are able to spend time with the child and the family, you will be able to boil down to the what is the main primary diagnosis. And then you see that it was depression which was going on, and then the disruptive behavior started, or it was ADHD going on, and then your disruptive behavior started. And along with disruptive behavior, then anxiety added on to it. So in that cases, then you have two options. If the disruptive behavior is too much, in those cases, you need to settle down immediately. So there you can use medicines to settle down the aggression. But if you have a window, always treat the primary diagnosis of ADHD or a depression or those things. So there I treat the primary diagnosis, and a lot of time I feel the child improves. Like recently I saw a child, class 8th. He was highly disruptive in the class. But when he came to me, what happened was that he had underlying ADHD. I started him a long-acting stimulant, 18 milligram. The mother came to me after 1 month, along with therapies going on. The child is far better. The medication got finished for a few days. The child behavior escalated. So mother was convinced that the medication was working with methylphenidate. I again started the medication modified. And since last few days, the child is more better. So teasing out, and that is what the clinical practice and the art is. Don't get just carried away with multiple symptomatology, somatic, conduct, behavior, hyperactivity. Try to use your clinical dictum, trying to use your clinical knowledge and wisdom, and see what is main core symptomatology. That's what.
One interesting question is there. Dr. Shama Rathod, madam. I work with children in conflict with law. For me, it's difficult to tell apart disruptive behavioral disorders from organized criminal activities and vandalism. What are the pointers? How do you differentiate that somebody is?
See, somewhere when you're talking about DBTs and organized criminal activity, my experience working, let me have a true confession. My experience with organized criminal activity and juvenile homes is limited. I did work for some time only, but I couldn't work for a long time. So, but the one thing I can say, in DBTs, you will see a lot of impulsivity. A lot of impulsivity is there. In organized planned crimes, what you will see, a lot of planning will be there. Lack of remorse will be there. And one thing which has come, there's a one subset of conduct disorder where they don't have the uncallous one. That is the one which is more go towards the antisocial and more goes for the organized crimes, ASPD. So that is the population you need to identify. So other disorders like ODD, other conduct disorders with underlying ADHD you treat and you get good results. People who have organized crimes and who don't have any remorse, no empathy, uncallous ones, there comes more towards the organized crimes are there. And when you talk to them, like I had in various high-profile cases, I had worked some of the cases. They don't absolutely, they say, it's okay, we have done it. What is there? We have done it, fine, we did it. But when you go to their history, Dr. Amrit, their past history, usually you find they had some ADHD symptoms, some conduct symptoms were there, which was not adequately addressed. But then at this point of time, they're absolutely lack of empathy, no remorse, and they get into an organized crimes. And they are almost like just on a trip to go into it. So this becomes a very difficult population to work with it.
So there's a question in the chat box, and Amrit, you like to go ahead?
Yeah. Sir, when we were being taught in our post-graduation, we were told that 1/3 of conduct improve, 1/3 of conduct remain like that, and 1/3 of conduct go on to ASPD. The dictum still holds on, or is there any change in the pattern?
There is no, whatever those studies are there, they still holds true. They still holds true, that goes. But what is the other subpopulation which goes into ASPD? There's a specific population is there, which goes into these things are there. So 1/3 do improve, and I believe more than 1/3 improve. So I can say, I will not, the study say same thing, but from my clinical experience, I can say almost 50 to 70%, almost 2/3 they improve, I can say. I've seen them improving now with so many long follow-ups, working in the mental health field, exclusive child mental health for almost 2 decades. I have seen, and what I get this thing is that I feel that if you're able to work a comprehensive management, not only focusing on the child, to working on the child therapies, working on with medication, along with working on the family, I have seen difficult to difficult cases improving. And when I get when now some of them have grown up to late 20s, early 30s, and when they refer other children, and then they tell me, you know, I came to you 10, 15 years back, I'm referring some child. I ask them, how are you doing? Say, I'm doing fine. I'm doing this profession. Then you realize that these children who have grown up are doing well. So that is where my follow-ups are, I can say from that perspective. I may be having some clinical bias, but I believe there's a significant proportion do improve if you have a comprehensive evaluation and comprehensive management. But there's no quick fix solution. There is no fast solution.
Okay, thank you, sir. Sir, from the chat box, suppose there is an adolescent in the clinic, and adolescent says, and we also agree, suppose that family is having more of the problem rather than the child, and it is very difficult to involve the family. They are already blaming the child and everything is put on it. Suppose we agree that actually the family is having more problems. So how do you handle such cases, such parents? And because they might be stunned if you say that you are having more problem than the child. So how do you measure it?
This is a very, 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 very important and very common clinical situation, Dr. Alim, which comes to me and comes to a lot of clinicians. So what is important in such cases? I never blame the parents. That's one of the golden dictum. Never blame the parents. Never make them feel guilty. I tell them, let's work with the child and let's work with the family. Let's work together. So I try to empower them. And I try to look some good things in the whole interview, which I can reflect back. If I'm able to reflect back some good thing in the interview, then I am able to develop a rapport. Correct? That's what happens with me. Correct? Can you excuse me for a minute? I think, just give me a minute. My daughter, I think, just a second.
Sure, sir.
Alim, और एक दो क्वेश्चन ले लेंगे फिर.
I think
21 हो गया.
Sorry, I'm back. Sorry. So in that cases, and so same case which I was telling about this class 11 student who came to me. So the family was where I knew the family was a big issue, but then I never blamed the family. So I met the father, I met the mother, I met the elder brother. I tried to understand the whole family, and the golden dictum, I never blamed them. I said, I want to work with your family. And simultaneously, I was giving importance to the teenager. Okay. And I used to talk to her alone. And when I used to listen to her, spend time with her half an hour, she used to cry. She used to say bad things about her parents. I used to just show an empathetic perspective. So in that way, what I was doing, I was trying to build a rapport with the teenager and try to contain the family without blaming and creating a guilt. Gradually, the teenager started coming to me on a regular monthly visit, and she started having therapy from my therapist. And she started taking the medication, which she was reluctant to take initially. I gave her the rationale why I'm starting the medication. I told her about the biochemical abnormalities which is happening. And she said, okay, I will read on the Google. I said, okay, you can read on the Google. I never deny any parent and any adolescent not to read, because I know they will read. So I tell, okay, you read about it. Don't worry. If you have any query, get back to me. I tell them side effects, so educating them. In this way, gradually, Dr. Alim, I'm able to build rapport with them. And whenever one more thing I've seen is which works, is that keep a smile on your face while you're working with such complicated cases. Develop empathy, but keep a smile. And those little smile while you're talking to parents gives you an edge. and use humor if whenever possible, slight humor, but not to insult, not to intimidate, not to make them feel, but use a humor and share some positive experience which makes them feel lighter. So try to make the environment lighter. Don't make it too heavy in your clinical setup. And then they go with a heavy smile. They feel, okay, it was very light. And then they come back to. So these are the small strategies which I have learned over the years and I use in my practice.
Sir, Kuldeep calls or wants to ask involvement of pediatricians. How much is it is increasing? How are you taking, and what to do if the parents are separated or divorced?
Acha, two questions. Now, see, pediatricians involving is why important, because pediatricians are the people, are the doctors to whom the parents goes for the first contact. So I work very closely with pediatricians. So because they go and tell the pediatrician, sir, we are having a problem. Pediatrician says, okay, go to this doctor. So educating the pediatrician is very, very important. Telling them what are the red alert signs is very, very important. That's all, these two things. So educating them and red alert signs and simple strategies. So whenever I do a lecture for pediatrician, I tell them what is the disorder, what are the red alert signs, and what simple strategies they can do in the office and when to refer. That's all. Now coming to the two cases of separation and divorce. Separation and divorce can complicate because there can be like a parent alienation syndrome, custody issues, visitation rights. I work with a lot of cases who are involved in custody. So what happens in such cases is the child is very good 5 days. On the weekend, he goes for the visitation rights. When he comes back on Sunday night or Monday morning, he's quite disturbed and he becomes aggressive. Within 1 or 2 days, the child settles down, but the visitation rights cannot be removed. Those becomes a challenging. So in separation and custody cases, you have to understand the whole scenario. And in that way, if possible, involve both the parents. The practical challenge, working with both the parents is almost very difficult because both the parents never come to your clinical practice. Only one parent comes to you. And the other parents keeps on trying to alienate or keeps on trying to blame the system or blame it. In such cases, what I've ended up is that working with whatever parent is available and whatever the child is available and building on his coping skills and involving my therapist. And if depressive symptoms are there, anxiety symptoms are there, using medication in such cases. So that's one of the cases which I'm working right now currently. The case is in the High Court. So in that case, the father keeps on putting the cases and the child does not even want to do the visitation rights. The father is again filed up. He becomes aggressive. He has underlying ADHD also. And he said, I don't want to meet the father. And whenever he meets father, he becomes so aggressive. So now he doesn't want to meet father at all. So these are the various complications which happens in such cases.
Thank you, sir. Thank you so much. I think we have covered most things here. Yeah, I think Dr. Devadatta.
I think there are 1 or 2 questions. One question which I thought it's very important is, do you see a lot of dissociation and somatization in this subset of population?
No. I see more dissociation and somatization in complex trauma cases. I see more in the trauma cases, complex trauma, complex PTSD cases, in those cases. But in DBDs, I don't see. Now, why this question is very important, Dr. Amrit, a lot of times, they can be situational, they can be aggressive or defiant, but not DBDs. They can be a little bit ODD can be there, little bit defiance can be there, but not so much of disruption will be there. That's what. So if there's underlying depression, anxiety is there, trauma is there, then yes. Then you see more of dissociation and somatization. Not otherwise.
Thank you, sir. Dr. Devadatta. Yeah. Your comment, please.
Comment shared a question also.
Can I ask the question?
Yeah.
Yeah. Thank you so much. Thank you so much for the comprehensive, excellent presentation, sir, where you have covered many aspects, starting very crisply, like starting from neurobiology to the risk factor, protective factors, and the challenges, need for comprehensive assessment, and the multimodal management. I have 2 questions. First is, to me, there are 2 challenges, as you have rightly pointed out, to convince the parents about the illness, because they usually think it's a deliberate presentation. And the other challenge is for the practitioners, where other modes of like we don't have professionals like psychologists or other, then the other modalities of management cannot be done apart from the pharmacotherapy. That becomes a big challenge for the psychiatrist. So your comments in this.
This is very, very important point, Dr. Devadatta, and this is what I learned from our senior professor, Professor Shobha Srinath, in many interactions with her, and during my posting also, while during my my MD days in 90s. She used to always say, if you don't have a psychologist, that's okay. You can do simple psychological interventions. So while you're prescribing medication, in those 10 to 15 minutes, you can tell parents simple strategies. So in such cases, I always use ABC. Appreciate the child, be with the child, connect and communicate with your child. Now I've added D and E also, digitally responsible, and E, eat smart. So I tell these simple strategies to the parents. Correct? I use these 4 A's. Accept your child, acknowledge your child, aware about the challenges, and appreciate your child. So using these simple strategies, whether it's OCD, whether it's depression, whether it's DBT, conduct disorder, along with medication, whatever you're writing, in a busy practice, just giving parent those simple, coming from you sitting on this high chair where you're seen as a doctor writing a medication, your simple strategy is there, can be there. I always use it, avoid the no word. No word is the most toxic word. Whenever then say, sir, hum bolenge kaise? How can we speak? I tell them, address it without using the no. So I give them. So if with your busy practice, if you're don't have a psychologist, if you're limited to some remote area, if you're just have a heavy practice, give every parent 2 or 3 tips, or make some handouts in local language, in Odisha, in Bengali, in Kannada, whatever it is, simple, and whichever type of profile of parent comes. Depression, give the depression one, Kannada with the OCD one, ADHD one, simple, if they can read. If they cannot read, that's okay. So making things simple in a complicated case is the first step.
Thank you so much, sir. Sir,
Hello, Dr. Deepak. Just a minute. My signal may go out anytime. It is just flickering. Wi-Fi nahi hai.
Koi baat nahi, sir, please.
This just to compliment you.
Thank you,
and
sir.
I would like to further discuss it. There is another point. There are communities who have got this deviant behavior pattern as a cultural ethos, and children from those communities are very difficult to manage, and families are very difficult to manage, and they are not rare. So a community orientation is also essential. But with a lot of thanks and my hats up, my signal may go off at any point of time. If I go with a lot of gratitude to for your presentation.
Thank you, sir. Thank you very much. Very good point about this thing is that I work with CCIs. I work with childcare institutions for last almost 2 decades now. And I work with multiple childcare institutions across the country also. And yes, sometimes this group activities and group cultural, deviant activities can be challenging. The important is to break the pattern, to identify the group leader. So identifying the group leader, identifying who is working on the group dynamics, and then understanding the psychopathology in the group leader is important. A lot of times, while my experience is that a lot of group things happened in the CCIs and various institutions I saw, but when we worked at one particular child who was responsible for series of activities, we were able to break the pattern. So there, I was able to work with the team, with my psychologist, with social worker, with the counselor, with the home. That means the whole ecological system. In that case, you are able to break the system. See, system creates system. That's what Patterson says, 1982. 1982, Patterson, very classical article. I really like this concepts, still 40 years down the lane. System creates systems. And systems are responsible for creating the defiance and deviant behaviors. So if you need to break, you need to break through the system. And that's where the Braun-Frenner, 1979, the Braun-Frenner ecological theory comes into play. So you work through the various systems, and you're able to break this. And that is the one of the main core concept of MST, multi-systemic therapy by Engler.
Thank you, sir. PK sir.
Well, thank you. It has been a very enlightening and enriching experience, and I think the same is true for everyone. And I would like to thank once again Dr. Deepak Gupta for his extremely comprehensive presentation on a very complex subject. I will just take half a minute or more that as his own presentation has highlighted that we have to work with the ecological system, probably we have to involve multiple other actors in the society. For example, if I were to comment on the parenting training, probably it has to start before they become a parent. Just as we talk about sex education, we may also talk about parenting education starting at the high school level. Similarly, we have to involve the other opinion leaders of the society and the lawmakers. And so seeing the complexity of the problem, we have to involve the several sectors of society. And maybe that cannot be taken at the clinicians level. It has to be taken at the societal and people in authority. With these few comments, I would like to thank once again Dr. Deepak and thank you all for this excellent presentation and experience. Thank you.
So just want to add to what you said, sir. Caroline Webster Stratton, she's at Washington, and she has this book called Incredible Years, a lovely book which I was exposed while I was at IOP almost 2 decades back. And she has come out the same thing, that yes, before they become parent and during pregnancy, how working on the effective parenting yes. styles can help. A very, very good article. Anybody who's ready, her name is Caroline Webster Stratton, Incredible Years. And a lot of papers on this, what you're saying is that. So if we can do such models, absolutely. And that's what Stephen Scott says. You work early, you're able to have a lot of economic saving. A lot of economic saving can happen almost 10 times because this conduct disruptive behavior disorders and a lot of impact on the finances and the economy.
Maybe the IPS as a society can take up this task and prepare modules and interact at the school levels. Thank you.
Thank you, sir. Thank you.
Thank you, sir. Amrit, over to you.
Sir, at the outset, thank you, Dr. Deepak, sir. You came on a phone call 5 days back. We thought, let's not discuss ADHD, we discuss something else. And with the digital era that has come in, I think we see a lot of more disruptive people coming to our clinics. And if you look at the last 1.5 years, it's so much. And one of the most, if you look at the A of it, it is the use of mobiles that is leading to a lot of explosions at home. So with the use of video games, violent things, a lot of porn, the whole segment is gradually changing the level, the type of disruptions, the type of interventions we need. I think that has to be again changed. So thank you, Dr. Deepak. Your presentations were excellent, but your interactions were way beyond what we wanted to have. So that was mind-boggling. PK sir is our teacher. We always respect him a lot. His insights are, as the experience he has. It's been wonderful. Thank you, sir. Dr. Devata is another young colleague of ours who is into child psychiatry. She was little silent in terms of her questions and all, but thank you, Devata, for coming, adding to our whole experience. We will call you again. Thank you, everybody. Dr. Tufan sir joined us all the way from Thiruvananthapuram. There's a conference going on, but he wanted and he joined in. A lot of people who always come in was even on a Kadwa Chowk. We were very worried that what will be the attendance. And Dr. Deepak, I think you must be very happy with the attendance. We had more than 280 logins. I think that's
Thank
great.
you very much for giving me an opportunity on a short notice.
No, I would like to tell thank you for you coming on a short notice. So Alim, thank you so much. Thank you, everybody. Thank you, Torrent. Thank you, IPS OSB. Another episode next week. It's 114. So next week will be 115. We are going strong. Thanks to all of you. Meet you again. Thank you. Good night.
Good night.
Thank you. Good night.
Thank you. Thank you, Dr. Amrit. Thank you, Dr.
Thank you.
Thank you. Good evening.
Thank you.
Good night. Good night, everyone.